you haven't bought this book yet, you need to buy this book. I was reading a lot of it today. This is a new book for us, too. We just got it last semester. This is an awesome book. It's published in 2010. And it's got the latest evidence-based research throughout the book, which is amazing. So anyway, I'll be on your cases to read this book. And the main reason I'm so adamant about it, I added a few slides today as I was reading the book. When it comes to infusion nursing, as an RN, this is your most significant thing you're going to be doing. This is the largest reason for malpractice and negligence in nursing and liability is infusion-related issues. Okay, so this is a huge area of nursing. You need to start absorbing as much information about this topic as you can. 90% of your hospital patients will have IDs. 70% of your home care patients will have IDs. We know that when we open up a vein, this is an open access to microorganisms. If we are not using excellent techniques, we could be introducing pathogens into their bloodstream. Okay, so I just can't stress it enough. I don't know if I told you, my dad died from a hospital-related associated infection at Loma Linda. And I had always been afraid that somebody in my family would contract one of these pathogens and die from it, and having my dad. So, but he was in the hospital for an extended length of time at a central line, and patients with the central lines are most vulnerable. And he ended up with a vancomycin-resistant bloodborne pathogen, which, yeah, he was gone in a matter of days. So anyway, it's dear to my heart. So but anyway, when you're practicing infusion therapy, these 4 things listed, I got this out of this current book because our last book, our Josephson book, was an excellent book, but things have changed. So you need to be remembering these 4 things. When you're practicing IV therapy, you're under the Nurse Practice Act in California. Whatever state you practice in, you need to know the state Nurse Practice Act for that state. Okay, you need to look at this very carefully to make sure you are within your scope of practice, within the Nurse Practice Act. The INS standards are the Infusion Nurses Society standards. So we want to be definitely within their standards as well. I think I've said this many times already in just our short weeks together. Hospital policy and procedure manuals. You need to become, wherever you end up working, wherever you're a student right now, you need to know where those manuals are and pull up those policies whenever you're doing any sort of nursing action and make sure you're within the policy and doing it according to that hospital's policy. Okay, and the 4th thing is the Joint Commission. How many of you are familiar with the Joint Commission? Raise your hand really high. Okay. The more you go through the nursing program and become a nurse, you'll become very familiar with the Joint Commission of Accreditation. We used to call it JACO, now we just call it Joint Commission. This is the accrediting body in the United States that if your hospital is not accredited by them, your hospital will not operate any longer. So when the Joint Commission comes into your facility, much like the Board of Registered Nursing, if this program were not running and operating by the Board of Registered Nursing standards, we would be shut down. Same thing with the Joint Commission. If your hospitals are not functioning at their levels of what they think you should be doing, you're done. Okay, so we look at the Joint Commission requirements and we take them very, very seriously. They're all about safety. They're all about quality of care. They're what we really want for our patients, to give them best care. Yes, question?
When we were in a clinical last semester, the nurses said maybe JACO's here, and we're not.
See? What hospital were you at?
We were at Kaiser.
At Kaiser. And what happens now in this time, and when I was a nurse manager, I went through the Joint Commission coming to my brand new Desert Valley Hospital. I was a nurse manager. I dealt with them for 2 days for 8 hours, face to face. And finally, all my fears with the Joint Commission are gone now because I realized they're just people. If you're doing a good job, they just want you to see the good job you're doing. But nowadays, if somebody picks up the phone and complains about your hospital, they can drop a visit on you with no warning. Same thing with the state of California. If if somebody picks up a phone and calls the state of California and said, my grandma's in the hospital and those nurses don't know what they're doing, I'm afraid my grandma's going to die because those nurses are unsafe. That's all it takes. And these people will come to your hospital to make sure that you are providing safe and quality care. Okay, so this is a very serious thing when it comes to our IV therapy, is that we want to make sure we're operating within these four bodies of, what do you want to call it, policy. Their policies, their suggestion, their recommendation. Very, very important. Let me pull this out a little. This way. Push it in a little. Here we go. Okay, so this I just took out of the book today. And then negligence. Negligence is defined by the Joint Commission. Now, this is the Joint Commission definition of negligence. And all of you have malpractice insurance, right? Malpractice is to cover negligence, hopefully. Failure to use such care as a reasonably prudent and careful person would use under similar circumstances. So that I'm nurse A and this is nurse B. If I'm set with this patient in this scenario, I'm going to do this nursing care according to all these policies and these governing bodies. This nurse should be doing the same thing, right? We should be doing the same type of care by the standards that have been set forth for us. So this is straight out of the book too, the new book. And then this I just want you to see, malpractice is a type or a subset of negligence. So 62.7% of the malpractice cases are against non-specialized nurses. By non-specialized, that means you're not a nurse midwife, you're not a nurse practitioner, you're not a nurse anesthetist. You're a regular registered nurse practicing nursing. Okay, so this is a large percentage of the malpractice cases coming against registered nurses. So you just need to be aware of it. And each one of us are liable for our own conduct. I put the page numbers that I was reading today because I believe this information should be foundational for every student nurse. Starting now, once you start learning about IV therapy. Because this is the majority of cases. It has to do with IV medication. IV, these bags. What kind of solution is this? What kind of additive is in this? This is my piggyback. This is my antibiotic. What's in this? Are these compatible solutions? There's a lot to know here. And the one thing I read regarding negligence, and I've known this from the day I became an RN, which is a million years ago. If a doctor tells you, give this patient this, and you do it, and that kills the patient, you're done. Okay? You're done. You will not be a nurse anymore. It won't matter what that doctor said to you. You are liable for giving that med because you should know what this is, what the side effects are, what the purpose of this is, what the purpose of this is, and know exactly what you're hanging and why you're giving it. Okay, you should never, ever, oh, I got to give this. Doctor ordered this. I got to give it. And have no idea why you're giving what you're giving. Okay? And that goes through nursing school. And we'll be asking you that as your instructor because we want you to understand you need to know why you're giving this. And if the patient goes, why am I getting that medicine? You need to say, because this medicine is for this. Okay, this is ampicillin. You have an infection in your body. We're going to be giving you ampicillin every 4 hours around the clock for the next 3 days. This is killing the germ that's in your bladder. Okay, we have to give it so many days to kill the germ completely. We need to know how to do that. The person we bought our house from in Huntington Beach, where we live now, was a man about 50 years old, went into Hope Hospital for everyday surgery. He was a super healthy guy, was given an antibiotic, died of anaphylactic shocks. And this is what his son told us. We're buying the house. Yeah. And here's the issue. When you're hanging IV solutions, and you're starting a new med or a new just solution, you should stay at that patient's bedside once you start that IV infusion and hang out for a while, okay? Because the guy that we bought the house from, he wouldn't be gone right now if his nurse would have been observing him, taking vital signs and everything else, and hanging a new medication. Any patient has the potential to have a reaction. And if you don't catch on to that and stop that infusion immediately, they run the risk of dying from that. So just let this sink in. the importance of when you're starting a brand new infusion or blood products. I used to hang a lot of blood when I was a med-surg nurse. Same thing with hanging a blood transfusion. You should be at that patient's bedside, taking vitals however many minutes apart they want you taking them, kind of like the epidural. Every so many minutes, talking to the patient, finding out how they're feeling, telling them, let me know if you feel any different at any time during this infusion. And I've had patients react to blood. All of a sudden, they're like, I don't know, I just don't feel good, I'm feeling hot. You want to stop that as quick as you can, change that line down at the site down here, pull out that tubing, get some normal saline, and stop that immediately. That's what you do. They're having a reaction of some type, we don't know why. Very, very important. Can't stress enough. Okay, so this is just some stuff out of your book that I feel is extremely important for you. Healthcare-associated infections, you'll see them referred to as HAIs now. That's the latest terminology. They're also known as nosocomial infections. Okay, these are infections that patients get from being in the hospital. Every hospital has the potential to infect patients. That's why I tell people, and that's my advice, I say get out of the hospital as quick as you can. Okay, because there are germs in there, there's superbugs, we call them, that don't respond to antibiotics. And the longer you're in a hospital setting, the more likely you are, the higher the risk is for you to contract something. So 2 million cases per year, 90,000 deaths per year. Okay, that's a lot. And the central line infections, this is the mortality rate, 5 to 25% that they're going to die if they get an infection in the central line. Okay, so not good numbers. Okay, so as far as, any questions about anything I've said so far? Okay, so as far as fluid balance fundamentals, all of you had what? Anatomy and physiology, right? Did anybody take chemistry? Okay, so you learned a lot about fluid balance. I'm not going to spend a lot of time on fluid balance right now. If you don't remember about fluid balance, our IV books always cover basics of fluid balance, but I want to get more into what I think is kind of the meat of what you need to know right now. And it's not about reviewing, you know, just the basics of fluid balance. It's on these slides, which is really good, but there's things on these slides that you've never heard of before that I want to elaborate on right now. Sensible and insensible losses is important to understand because once a patient has an IV started, now they're going on I&O, right? Strict I&O usually. So if a patient, like our labor patients, are breathing through contractions and they're sweating, they have a lot of insensible losses. So just understanding what sensible losses are, we can measure them very distinctly. Insensible losses, we can't really measure. We can just kind of estimate by how much our patient is breathing and maybe coughing and sweating, diaphoresis. Okay, so I'm not going to go into that. And then just understanding the intracellular fluid and extracellular fluid. So ICF is 2/3 of the adult body fluid and 1/3 of extracellular. And just reminding yourself, did you guys get to do your blood type when you were in anatomy and physiology? No. You have to type our own blood. That's back in the good old days. Okay, and then this chart is really nice because you get to see within adults how ECF and ICF, how they're a little bit, the ECF is smaller, but with the infants, we see how much the ECF and the ICF, so that with children and pediatric patients, if they have vomiting and diarrhea, they can become dehydrated so much quicker than our adult patient. And we'll get more into that when we get into pediatrics, but it's just something to understand that there's a difference. I'm not going to talk about osmosis, but osmolality is what our IV fluids. Now these fluids are what you're going to need to learn today. Okay, so isotonic fluids are what we're giving our labor patients. It's LR. So lactated ringers is one of our most common isotonic fluids. And then the other one that you'll see commonly used is 0.9% sodium chloride. And with our pediatric patients in our next 8 weeks, we'll see the majority of our peds patients on 0.9% normal saline fluid. Okay, so you need to know examples of isotonic, hypotonic, and hypertonic fluids. And the two most prevalent types is LR, lactated ringers, and normal saline. Okay, 0.9 normal saline. They just expand the extracellular fluid compartment. And then hypotonic, if the cells are dehydrated and we want fluid to go into the cells, we're going to use a hypotonic solution. So our two most prevalent hypotonic solutions are half normal saline and D 2.5% water. So you need to know like the top two most prevalently used hypotonic solutions. All right. The danger with this is if we're not careful, we can actually cause the cells to get too much fluid and then cell lysis may occur. So it's going to be a balancing act. And then hypertonic solutions causes the cell to shrink. So in patients like burn patients where they get so swollen, we would use a hypertonic solution for a burn patient, or a trauma patient where there's lots of swelling in the tissue and the cells. Okay? And so our most prevalent type of hypertonic solution is D5 normal saline and D10W. So you should know those. You should know your two isotonic most prevalently used. But there's many more in each of these three categories, but these are what most commonly you're going to see used. Okay. And now types of fluids. Crystalloids. This is a crystalloid. This is a crystalloid. If I take we used to mix our own piggybacks back in the old days. I'd have like powdered ampicillin, and in peace you might get to mix your ampicillin. We would take some water, like some normal saline, and mix it with those crystals, and that forms a solution. So that's what this is the type of fluid I'm talking about, where we can actually make a solution out of it. Crystalloids are what the majority of our IV fluids are. They're crystalloid fluids. Okay, for a normal adult, we usually will give a bag of 1,000 mLs over 8 hours, average adult. Maybe a small adult, this would be a 10-hour bag. So crystalloids, you can mix things in them. Okay, and there are isotonic, hypotonic, and hypertonic, are crystalloids. Okay. 3 liters of crystalloid is equal to 1 liter of blood loss. So if you have a patient who's lost a lot of blood, nowadays we're less likely to call the blood bank and get a unit of blood and hang a unit to replace their loss. We're more likely to just replace it with fluids. Okay, so 3 liters of fluid we would be replacing for 1 liter of blood loss. Hydrating fluids, they might call it a challenge or a bolus. We use normal saline or lactated ringers, and we can do that to assess a patient's kidney function. Hydrate a patient, which we'll use these in labor and delivery. We'll use the normal saline in our pediatric patient to kind of bolus up and load up a severely dehydrated patient. And children, don't worry about calculations yet. We'll be doing plenty of calculations soon, like every week once we get to these. Okay, and then colloids are the other type of solution. So we have crystalloids, which are these, and then we have colloids. Okay, so colloids, you can't mix anything in them. They're also known as a volume expander. So this, where it says volume expander, highlight that. We're going to be adding volume. What I used with sick babies, when a very severely sick newborn is born, and they have to do a full coat on that baby, and I've had to do that with the NICU doctors prior to a team arriving. They just open up instead of clamping the cord, they open up those lines, and they actually put an umbilical cath line in, and then we would give albumin in 10 ml syringes, usually 2 20 total, 20 mLs to expand the volume of their blood, okay? I haven't used dextran or mannitol, but these are your 3 types of volume expanders. So just understand there's a huge difference of a crystalloid solution like this than our volume expander. It's all colloids, okay? We're trying to increase blood supply rapidly. Okay? So we don't dissolve anything in a colloid. Okay, we don't mix anything. Okay, so does all that make sense with crystalloids and colloids? That's something you need to know starting today. We have crystalloid solutions and colloid solutions. And we need to know why, especially with a volume expander. Why are we doing that? Okay, so IV therapy. The great thing about starting an IV is we can do so much so quick with the patient. I think the greatest thing about Western medicine is our ability with an acutely ill patient walking into an ER and how quickly, once they get some lines in that patient, how quickly they can help turn around a patient through the capability of the IV, IV meds, IV solutions, maybe giving blood, whatever. So that's the great thing about having an IV line accessible. We can do large fluid volumes all at once if we need to, and we can give drugs rapidly. So this is what's great about IV therapy. Some meds are only given IV. Okay, and it's really important when you're giving meds to always look up what is the route. Always know that. Some meds, if you give them IM, create damage to the muscle. So it's a much better choice is to give an IV med. Okay, so there's 2 types of therapy. There's maintenance therapy, which I've talked about. So maintenance on a normal adult, this is our primary line right here, would be running at 125 per hour. Through a pump like this, we would set this pump for 125 mLs. Okay, that's maintenance. That's just to maintain homeostasis, right? So replacement therapy, we're going to be replacing. So if a patient, I have an example later on in the PowerPoint of replacement therapy, where if a patient is losing so much through the GI system or through maybe a drain, and the doctor wants to replace the loss, that's considered replacement therapy. So that goes above and beyond this maintenance line. So we'll get to a slide and we'll actually do a problem where we're replacing milliliter for milliliter replacement every 4 hours, for example. Okay, does that make sense? Maintenance therapy. In a test question, you would hear that. The maintenance IV is running at 125 mLs per hour, for example. And now the doctor wants to replace losses, so replacement therapy. So there's 2 different infusions we're talking about at that time. Okay, so maintenance water is the priority. How much of your body weight as an adult is water? Who knows that? What? 60%. Yeah. So when we are over half water, it's really important, especially on a hot day like today and tomorrow and the next day, to be drinking fluids, right? So we're going to get dehydrated. We're going to keep losing fluids in this heat. So the LR, I used to tell patients when I was going to start their IV, I go, have you ever seen those Gatorade commercials where Gatorade gives your body what your body's thirsty for? That's what LR does. It's got electrolytes in it. So it's not just water. It's got needed electrolytes to keep their electrolytes nice and stable. And it's good to explain things to patients when they have no idea why you're doing what you're doing. If it's D5W, we used to use a lot of D5LR, giving them unnecessary added dextrose. And through evidence-based practice, they determined our patients don't need all that sugar. So let's just stick to the electrolytes. So here it is again. The adult needs 3,000 mLs per day. So that's going to be 125 per hour. Just a good little thing to know. If it's a really small, petite patient that maybe weighs 80 or 90 pounds, we'd probably give her 100 mLs per hour. Okay? this slide, put a big circle around this and put save until pediatrics. Because I don't even want you to think about calculating maintenance rate on a pediatric patient right now. It's just too much. I want you to get the basics for the adults right now. So we'll be doing this. When we get to peds, you'll be calculating the maintenance rate on every little patient you have by weight. So it's a harder thing to do. So not today. Save it to later. So here's replacement therapy. It says on the third bullet, potassium is often needed in these patients. But potassium is also a medication that can kill a patient like that. If we give potassium, too much of it too fast, what's it going to do? What is potassium going to do? It's going to stop the heart. And there was one of those crazy nurses killing patients. Did you hear about that one guy? He was shooting potassium, I think into their IV. And it took a while to catch on to him, but he killed a bunch of patients. So anyway, that was really sad. But just with the use of potassium. Okay, so always check kidney function before administering potassium. Why would we do that? Why would we want to know kidney function?
Make sure they can excrete it.
Yes, to make sure they can excrete it, so we don't overload them. Exactly. That's it. Okay, so replacement is achieved on ongoing daily basis, and we're going to go according to what's ordered for that patient. It's either going to be over 24 hours and 4 hours, however the doctor wants the replacement given, we're going to be replacing as ordered. So that's, again, you're going to need to know how this is going to be delivered, and it's on an extra additional pump. Okay, so we would have, this pump right here has two sides, so we could keep our primary line, our maintenance rate going through here, and then through this we could be doing our replacement therapy. It'd be two separate infusions. Okay? Okay, so here's our replacement therapy case study. An adult patient is 1 day post-op abdominal surgery with an NG tube. The maintenance fluid are D5 half normal saline at 125 mL per hour. The physician orders cc per cc, ml per ml, NG tube fluid replacement every 4 hours with lactated ringers. The nurse measures the last 4 hours of NG tube output at 400 ml. What will the nurse now do? What will be the, not the restoration, the replacement IV fluid intake for this patient over how long? And what will be the total hourly intake? Okay, so let's just figure that out. So the patient's lost 400 through the NG tube, and now the doctor wants it replaced ml for ml over 4 hours. Patient's lost 400. So how are we going to administer our replacement therapy? 100 mLs per hour for the replacement. The maintenance, on the other hand, is still infusing over here at 125 an hour. So the combined total would then be, what? 225. So we have our replacement over here, and we have our maintenance over here. So just understand, when it's replacement, it's replacement. It's going above and beyond the maintenance. Okay, does that make sense? All right, we'll keep going. Okay, so with IV equipment, back in the old days, when I was a new grad, it was pretty much all glass bottles. Before these were invented, but now it's pretty much all plastic. There are a few IV solutions that can only be in glass bottles, so you will see the glass bottles, but for the most part, you're going to be seeing these nice plastic bags, which are great. And let's see, the spike. The reason I brought stuff in here is just so you can see. This is the spike. And when we're putting together IV equipment, it's all done using sterile technique. Because one of the ways our patients get infected is by us not using good technique. Okay, so when we open this out of a bag, and I actually brought one that hasn't been opened yet, so you can see it. And we pull the top off of this. We keep these both very sterile. And if they get contaminated, you discard them. Okay, very important. So we just put our spike into our bag, and we're good to go. Alright, so that's our spike. The drop orifice or the drip chamber, I usually call this a drip, that's what this is right here. And when we're not using a pump, we'd be counting these drops per minute. This is also the drip chamber. Okay, so you need to know these terms, what these mean. Okay, and then the clamp is right here, this roller clamp. This is off right now. It's got this line completely shut off because this is the piggyback. But to open the clamp, you push it all the way up. And to turn it off, you put it all the way down. And you guys are going to be doing IV piggybacks. In fact, after today, if you have an opportunity to do an IV piggyback with your nurse or your instructor, please do it if you have that chance. Because you're learning the theory part of it today, and we'll have IV Skills Lab next Tuesday from 3 to 6. And you'll all get to do a lot of hands-on with the supplies. The injection ports are, let's see, here's an injection port right here. These little things. So if we're going to connect, let's see where this one is. Okay, so this one is connected before it goes into the pump. That's where it needs to be. In pediatrics, a lot of times we might put our med down here closer to the site of the patient, depending on what we're going to administer. But that's what these are. These are ports. So each tubing has at least 2 or 3 ports. And when we use these ports, what do you think we're doing with alcohol? We are cleaning these things like our life depends on it, okay? We're using a lot of friction, and we're taking our time and cleaning these ports before we're attaching anything to them, okay? And we're wearing gloves, okay? The Infusion Nurses Society recommends the use of gloves anytime you're dealing with a central line, anything close to a patient. When you're doing IV piggybacks, they don't really recommend that you have to wear gloves, but with our program, we just made a decision and curriculum committee just to use gloves all the time. So when we're dealing with IVs, we're going to be wearing gloves. So remember that right before you go to touch your equipment, that's when you put on the gloves. You don't want to be doing all this other stuff with these same gloves on and then go work with your IV equipment, okay? You want fresh, clean gloves when you're dealing with the IVs. Super important. Because the research I was reading in the textbook was showing how basically 100% of healthcare workers carried, not staff was like 60%, but there's one of the pathogens where 100%, because they were testing them all, even with good hand washing, or actually had a pathogen on their hands. So we have to be thinking like that all the time. The filter in the blood, in our skills lab, when you're giving blood, there's a special tubing that comes with blood, and it's got a really huge filter in it. They have the thing in the skills lab. So just take a look at those when you have time. But you always do a fresh filter with each unit of blood. Okay, it's a really nice system. Okay, so you need to be familiar with the parts of the IV tubing and the bag. Now this is really important, your administration sets. Your administration sets come packaged like this. The macro drip, you need to highlight this, and yeah, this is something you need to remember and write down. The macro drip will come in various drops per ml. They're either going to come in 10 drops per ml, 15 drops per ml, or 20 drops per ml. The drop factor is something you must know. If you're not using a pump, St. Joe's, I guess they're just using no pumps, and it's all gravity drip. So you must know the drop factor because you're going to be running your IV drops per minute and doing that calculation. So the drop factor is something that's given on this packaging, and it's usually in really nice big you'll see the big nice 20 or the big nice 15 drops per ml. That's an important thing in your calculation to know the drop factor. And then the administration set types. Primary, this is my primary line. My secondary, my intermittent piggyback, is hung higher than the primary. When I'm going to infuse my amp, that's when I hang it like this, because gravity's going to be bringing this down over this one. Okay, and then when this is done, we put it back up. It's stuck. Put it back up on the, up here. Okay? But when it's a secondary is going to infuse over it, then we're going to drop it down. So now this is a secondary infusion. This is a primary infusion. This is also known as a piggyback. It's an intermittent infusion. So you need to know those terms. Piggybacks are intermittent infusions. Okay, we're going to infuse this for maybe 30 minutes or 60 minutes, depending on what the med is and how it's ordered. We're going to look this up. We're always going to look up our piggyback meds and say, what's the administration time? That's all in the med book. Okay? Microbore tubing or syringe pump tubing. This is a little syringe pump down here. We're going to see a lot of these in pediatrics. This tubing is a special tubing. This whole tubing, it's so tiny. It's microbore tubing. It's just 1 ml in this whole tube. It's amazing. So this is called microbore tubing. Okay, we'll be using these in peds. You'll see these a lot. And we'll actually practice setting up these syringe pumps at our IV Skills Lab day. Okay, so syringe pumps, these are designed for little pediatric patients. So instead of a peds patient having a piggyback that looks like this, the little peds patient's piggyback looks like this. Just pull it out. This is their whole ampicillin because they're little. So we don't want them getting this big, massive volume of fluid, right? So it's concentrated and it's down for a little tiny infant size, right? And as soon as you can, get in the Skills Lab and play with this equipment. Because if you're at Fountain Valley with me and Gina, we're going to have you guys working with this stuff on the very first day. Because it's fun. It is fun. The volume controlled sets of Veratrol, we're not really using those anymore. We stopped using Veratrol. They were using those at Fountain Valley. And so you really aren't going to have to know about this anymore. You can put a line through it because we're not using them anymore. Blood administration tubing, I mentioned, it's completely different than this. It's a much longer drip chamber with a huge filter in it. So just make sure you look at that. And then extension tubing, they actually have tubing that just attaches to this line. The extension tubing is about that long, but it will just give your patient better access. If they can move around a lot and they can get up and stand and walk around, you're going to want to give them some extension tubing so they're not so tied to this pole. Okay. All right. Any questions about any of our equipment? Okay. And then our infusion devices are set to deliver mLs per hour. So when you're doing a calculation for a pump, it's always mLs per hour. Okay. Controllers gravity flow, such as dial-of-flow. We don't have a dial-of-flow to show you, but with gravity drip, we're going to be counting drops per minute, and it's going to be controlled by our roller clamp. Okay, so this is what's going to determine how fast my IV drips. And we hold up our watch and we count it for a minute. See? It's not going to really go to the pump. But anyway, that's how you do it. It's all through the roller clamp. Okay? Okay, next slide. The syringe pumps, I just told you, this is for IV piggybacks. And on our little patients, they infuse either for 30 minutes or 60 minutes. Super important to ask a lot of questions when you're in pediatrics. Because when the babies are really small, we usually extend their infusion to 60 minutes. Things like vancomycin have to be a 60-minute piggyback. Certain meds have to be a 60-minute. But sometimes on smaller patients, we have to extend the time because their little bodies can only handle so much going in. Okay. And then PCA pumps. Did any of your patients have a PCA pump after their C-section? Have you guys seen a PCA?
Yes.
Okay, did you see those last semester?
Yes.
Okay, so you know, the patient can push the button, and actually when you set up your PCA pump, I used to set these up when I was at Kaiser Riverside. All the C-sections had their PCAs, we set them up in recovery. There's a lockout mechanism. They can get so many mils of the medication every 10 minutes, for example. So they could be pushing this thing 100 times, and they're only going to get enough medication. They won't overdose on it. That's the bottom line. It's set very safely, And I know when I've sat with patients before and they have a PCA and I'm like their friend or family, I'll be pushing the button for them because I want them to get their full dose. But anyway, they can't over-medicate themselves. They're really a safe way to give med, and it's just nice where they can be giving it to themselves. It's a really nice. I think PCAs are great for the first 24 hours. Okay, so the delivery method is based on purpose of the therapy, patient's age, diagnosis, and condition of veins. So there's peripheral, there's intraosseous is used on pediatric trauma patients, usually in the emergency room, goes into the bone. And then there's the central line. Intraosseous you're probably not going to see, but just to be aware that that's a way to treat little pediatric patients like when they're in a car accident. And they bring them into the ER, and they can actually infuse things into the bone, and it's an excellent way to infuse fluids into them. Central lines you're going to see some in pediatrics in the PICU, but you'll see a lot in third and fourth semester. You'll be dealing with central lines, and you'll actually start IVs next semester in third. Can you believe that? I know. But right after your psych rotation, you'll be starting IVs. So my recommendation is get really familiar with this awesome book you have. When you have spare time, read. This book is so good with evidence-based information for you. Which means, evidence-based means we've learned from our mistakes, okay? It's a really good thing. We've changed things because as nursing, we've seen these things play out, and then we've changed our policies and procedures as a result. So any phlebotomists in this class? Okay, so then you know what a scalp vein needle is. It's a little butterfly, yeah. We used to, when we used to do oxytocin challenge tests, start a little IV with the butterfly back in the day, and anyway, I used to use butterflies a lot. So butterflies are little needles. They might use them in a peds patient, or for blood draws, or just short-term IV therapy. We don't usually like to leave those in for any length of time. Over-the-needle catheters are what we use nowadays. And so when you start your IV, you basically do it at an angle to get into that vein, and then once you're into the vein with your catheter, you pull the needle out. And then the catheter stays in. And that's an important thing to tell the patient. I always told patients when I started their IV, I'm using a needle to get this in, but once we're in, this little flexible plastic tube is staying in, and there'll be no more needle in your body. Okay, and that kind of gives them peace of mind, just knowing that. So I think we used to have to use 18s on all our patients because it was high risk. 18s are big, and they can accommodate a blood transfusion if you need to give blood. So the gauge is 14 is the widest bore. Hopefully you never have to use a 14. 18s are pretty big. 18s and 20s are best for our adult patients. Okay, then intraosseous, again, emergency situation, children under 6, placed in the long and injured bones. And it's a great mechanism to get fluids into a child, a trauma patient. Okay, and then central lines are long-term access. Nurses actually you can get certified to place these lines, and you do the dressing changes on these lines. And these are really important to use strict aseptic technique and to do your very best not to allow them to get infected. So these are the sites. And then the PICC lines. A lot of the oncology patients have the PICC lines. I had a friend, a 26-year-old girl I knew that had cancer. She had a PICC line. And then a lot of your pediatric chronic patients will have PICC lines. So here's, the PICC lines are the ones that may be inserted by an RN. And that just shows where the PICC line goes in and how it's got the 2 lumens. So you can do several infusions simultaneously. And then here's a portacath. And those are implantable, surgically implanted. That's for 2006. These are for other chronic patients that are going to be having a lot of IV interventions. And then this is just essential, the hip pin. Do any of you work where patients have central lines? Okay, good. So you see central lines and you know how to be really careful, and that's good. Okay, so continuous infusions, primary line, which is what we're going to end up doing. We're going to be doing calculations of our primary infusion. That's what we're going to do today before we leave. It's calculated in either drops per minute or mLs per hour. Okay, so you need to write that down and get that in your head. It's either drops per minute or mLs per hour. Two very different calculations. What else can I say about that? We're going to monitor. We always monitor. Once a patient has an IV, every time you go in the room, you should be assessing the IV site. Okay? Every time you go in. And basically, you can look at the site. You can ask the patient, how does your IV feel? Do you have any pain, any tenderness at your IV site? You will not go wrong if you do that a lot. Okay? It's nurses who neglect checking that IV site and assessing it regularly, where we're going to get an infected site, we're going to miss it. So it's just really important. Okay, verify and document infusion solution, rate, and condition of your site. I know in peds we're documenting on their IV sites, I think every 2 hours they have an IV. Usually it's every 2 hours on a regular floor. It's hourly in the PICU. Hourly in ICU. Okay? And then intermittent, just remind yourself, intermittent infusion is synonymous with a piggyback infusion. They're the same exact thing. Okay, and they're going to infuse over 30 to 60 minutes. We want to make sure we have a compatibility of fluids depending on what this has been mixed in and what this is. Okay, so that's important for the nurse to check compatibility. They usually have these big charts in their med room posted somewhere. Sometimes they just have them in a med book. But it's always important to make sure it's compatible, your solutions. And we're using needleless systems now, which is really nice. And then direct injection IV push. We won't be doing any IV pushes this semester, but we do saline flushes. We'll be doing that on pediatrics a lot, where we will push a little saline fluid through the IV. That's when they discontinued the IV, and now they've just blocked it off. We call it a HEP block or a saline lock. And then we will flush that X number of hours. So if the doctor says flush it every 4 hours or flush it every 8 hours or flush it once a shift, you'll be flushing those sites with normal saline. Many of the pediatric patients, once they go to that saline flush, will get their piggyback, every 4 hours, every 8 hours through that. So we flush it with saline. Saline will run our infusion pump usually through a syringe pump. And then once our med is done, we'll flush it again with normal saline. So we used to use heparin at the end of that, but we have since stopped doing that. So we do saline, administer the med, and then saline. Okay, that's really important to keep these sites nice. Okay, so we never give potassium IV push. I mentioned potassium. It's a deadly drug if given inappropriately. In pediatrics, all those kids have potassium in their IV solution. So whenever you get an IV bag from the pharmacy, it's 2 RNs. You check it together and sign it off. Okay, because there's potassium in it. We want to make sure it's the right amount. We want to make sure we infuse it at the proper rate. And that rate is determined by the child's weight. Okay, so these are your 4 essentials of IV infusions. You need to know the volume. This is what the doctor should order, the prescribed time. So volume would be like 1,000 mLs, or this is 500 mLs. Time would be every 8 hours, or every 10 hours, or every 12 hours, but you need a time frame. The drop factor is something that we will know. The doctor will not put that on his orders. But that's something we would get from our bag. The drop factor is listed on the bag. It's either what? How many mLs? 20? 15? And what? 10? You're welcome. But the drop factor, that's our responsibility to get it off of this packaging, okay? And then the mathematical formula. Today I'm going to challenge you to start memorizing these formulas. Try to get them memorized before you leave class today, okay? Because you need to know these for the rest of your life, basically, as a nurse, all right? So, this is our formula for a pump, okay? It's volume divided by time. That's it. Volume, so if it's 1,000 ml, and the doctor wants to run it over 8 hours, which is our average adult IV infusion, 1,000 divided by 8 hours. And what is that? 125 mLs per hour. And the mLs per hour, remember that. Okay, so that's a pump question. All we need is volume and time. And then with the drop factor, on this question we're given the drop factor, it's 10 drops per ml. Physician orders 1,000 ml to infuse over 8 hours, gravity drip. So the drop factor is 10. So this is the formula using dimensional analysis to calculate out drops per minute. So we start with putting the 10 drops over 1 ml, multiply it by 1,000 mLs, and mLs over the time frame, 8 hours, times 1 hour over 60 minutes. So it's really not hard to do, and then we get 20.83. We have to round up or round down. We can't set our pump at 20.83. I mean, we can't set this at 20. It has to be 21 drops per minute, you know what I'm saying? And we'll be doing that with our watch. That's how we do a drop factor. We stand here with our little roller clamp, and we adjust the drops in this with our watch. Okay? So those are your two basic problems. And those are the formulas you need to memorize. They're really not that hard. This is the second formula. And we're going to do a lot of problems after our break. Okay? Does this make sense? Because you know dimensional analysis, right? It's just plugging in what you've already learned. And we just need the drop factor. Okay, any questions on this? We'll be doing a lot of these on the board after the break.
Which we'll get from our package.
Yeah, get it off the package, yes. Okay, so the saline lock method I just mentioned, we check patency by flushing 1 ml of saline. Okay, 1 ml of saline, we administer our piggyback for 30 minutes, and then we flush again with 1 to 2 mLs of saline. We used to add the heparin after that, but we've stopped doing that. That was called the SASH method. All of you heard about, what's his name, Babies, the famous actor that had the twins in ICU, I think it's Sears, and there was a mistake made with heparin. Remember hearing that? What's his name? He played the dad. Dennis Quaid. He played Bethany's father in Soul Surfer, so I know him because of that. But anyway, so he had twins in the NICU, and this is when we were using heparin to flush lines, right? And instead of getting the hep flush, which is 10 units in the amp, they had 100 units of heparin. So 2 little tiny babies got all that heparin, and miraculously nothing happened to them. But that's when things changed. I watched that closely. You know, when you have a high-profile case like that, and all it was, the Medra and the Pyxis, they accidentally got entered into the wrong drawers in the Pyxis, accidentally, because they looked so similar. That was part of the problem is that they look like the same. Like, usually they should try to change the color or something to make them differentiate. But the 10 unit and the 100 unit were so similar. So error happened. So in discontinuing IV, has anybody gotten to discontinue an IV? Yay! 2, 3, 4, 5. Good. So this is just remember your equipment that you need. You can do that with an RN or with us, your instructor. But by the end of the semester, you should feel really confident at discontinuing IVs. Okay? Any questions about that? Any of this? We're not doing complications until next week. sure you probably, did you have patients last semester, geriatric patients that are confused? They're not completely. So with IV therapy, you know, I've had patients rip IVs right out of their arm. Did you see any of that happening? So we want to do everything in our power to prevent patients that are confused from ruining and taking out their IV. Mainly because their vessels are just so fragile, and it's always so hard to get into their veins usually anyway, and then to lose an IV because the patient's confused. So it's just a high priority to be thinking safe, thinking where to put the IV, where it's less likely to get ripped out, and to secure it really well. We used to use a lot of restraints. Did you guys use a lot of restraints last semester? Yeah. Okay. We don't want them to rip out their IVs, right? Did you ever see IV started here? This is the worst possible place to start an IV. Usually, when patients are out in the field and they get picked up by a transport team, a lot of times they're going to put IVs right there. But it's the worst place. And so, if you get a patient, I would always move that IV to a better site. Because it's just a matter of time before you're going to lose this site. Anyway, just a little heads up. We usually start them right here. There's a great vein right there. And so they have complete use of their hands, and they can vein it. So yeah, that's something to think about when you start IVs. Okay, what else? Developmental considerations with kids. You may have the opportunity to help your nurse to restrain a little child for their IV start. It's never fun. It's a nightmare. But what they do is they have this freezing spray that actually freezes the skin. So it really does reduce their pain where I don't think they have any pain with that freezer spray. But they're just so freaked out. You know what I mean? They're like in, ah! So if you have the opportunity, your little peds patient is going to have an IV started, just help with it so you get the experience of what it's like to work on a little peds patient, and it takes teamwork. You're not ever going to be able to do that by yourself. My little granddaughter got hurt recently. Well, no, she got sick, and she was in the ER, and she had to have an IV. She was doing really good, and then when the gal showed it to her, she just let out the most blood-curdling scream. But the nurse was awesome. It was at Mission, Chocolate Mission. But anyway, we will monitor these sites, I'm telling you, every 1 to 2 hours. Intensive care, it's every hour. Charting it, what are you seeing with that IV site? What is the patient telling you about the IV site? Very important. I say very important when I'm talking about legal implications. You've got to be thinking legal as a nurse all the time. What would happen if I didn't chart this and I had to sit in a court of law? You must think like that as a nurse, because people are sue happy in this state. They want to sue everybody and blame everybody for their bad outcomes. So always be thinking, especially with IVs, what do you want to be sitting in court? You know what I mean? I never have had to go to court because Kaiser was so good at preparing us and teaching us and how to be conscious about that and be safe. And I never had to go to arbitration either. And I had many of my colleagues had to go to court and testify. And so just cover yourself, you guys. Cover yourself. And if you see one of your colleagues not charting, just say, don't forget to chart that, you know. Cover each other. Peds IV therapy, we won't go too much detail on this because we're gonna get hammered when you get the peds content with it. Okay. And then there's our book. All right, so let's go ahead and take a break. Shut you down. And then we'll come back at, how about 20 till? Yeah, oh no, keep them. I'm going to do that for roll call. Yeah. Thanks for reminding me. I want to know if you can find me. I can. There you go. Glad you were there. You're welcome. welcome. My pleasure. Does somebody have the attendance sheet? Oh, good. All right, get your vocabulary out. Yeah, get your calculator out. Okay, so we're going to do attendance and vocabulary simultaneously. Okay, Janet. Number 1, hypotonic solution. Okay, listen.
Hypotonic has the least electrolytes, so examples 0.25 NaCl and 2.5 dextrose.
0. What? Sorry.
I know, I 1 second.
0.45 is that what you said, sodium chloride? 2.5 dextrose. Okay, what else are the 2 most common used for, oh no, this is good. And then, what does it do to the cells? Did you say that?
The fluid stays in the vessel and not move the fluids around.
Okay, well, hypotonic causes the cell to swell. Yeah, hospitalysis. So that's the important thing with a hypotonic solution to remember. If you're infusing that, you don't want to overinfuse that one. So good job. Okay, Vanessa, number 2.
I put greater than 375.
Milliosmoles.
It causes cell shrinkage.
Yes.
And common are dextrose 5% and 0.9 NF.
Yes.
And it's used with conditions like burns or trauma.
Good. Excellent. Okay, good job. Okay, Liz, number 3.
Fluid with the same concentration or osmolarity,
Osmolarity, I know. Yeah.
than blood plasma, between 240 to 340 millimeter osmolarity per liter.
Gotcha. Okay. And does it have any action with the cell?
No.
No. What does it expand? ECF. Extracellular fluid expands that. Good job. Okay, Rod, number 4.
Slide solution. Organolazine contains electrolytes and non-electrolytes which will diffuse into all body fluid compartments and pass through semi-impermeable membranes.
Okay, good. That's our most common IV fluid. It's crystalloid. And we can actually mix medication with the crystalloid solution. And yeah, that was good. Okay, next is Anne. What's number 5?
Chlorine solution and glutinous substance called capsule when immersed in a solvent.
Okay, good. Okay, good. And so what's another terminology for a colloid solution? It's a volume expander. Yes. Okay, so that's the key thing to remember there. It's a volume expander. We need to increase this patient's volume quickly. Okay? We can't mix anything in a colloid solution, right? Okay, Joaquin, number 6. Go, Joaquin, go.
In the Fusion Nurses Society, they set the standards for fusion.
Yes, they do. Very good. Okay, Julie, number 7.
I have a standard administration set.
Right, the primary set is your standard, it's your main line. In other words, your primary infusion is your main line IV. Okay, good. Okay, let's see, who's next? Becca, number 8.
Secondary set, also known as IV case bag, which is higher than the primary bag. And
Right.
is not required when using an IV.
Right.
Also known as intermittent infusion.
Good, yes.
30 to 60 minutes.
It's a normal infusion rate. Very good. Good job. Okay, so secondary set, also known as intermittent, also known as piggyback. All interchangeable terms. Good. Okay. I want my pen. Okay, Regina, number 9.
Over the needle catheter?
Yes.
I don't know. Am I just supposed to say what it is? I
That's
didn't see that
okay.
until just now. But
Okay.
I mean, it's like what you start in my infusing.
Right. So that's
I
why
mean,
they
it
use
goes over a
infusion
needle, you take the needle out, and the catheter stays in, and it's flexible.
device. Right.
Yeah.
Well, that's what we use 99% of the time. Okay, good. Okay, number 10, Janine, maintenance therapy.
Maintenance therapy provides nutrients that meet the daily water needs.
Yeah, and electrolytes usually. Very good. For the adult, average maintenance rate is what? Average, what? 125 mL per hour. So when you think maintenance rate adult, just think 125 mL per hour. Good job. Okay, Porphyria, number 11.
And takes care of fluid, electrolyte, and blood product deficits of patients in acute distress. This type of therapy is supplied over a 48-hour period.
Okay. And so we're replacing above and beyond the maintenance therapy. Replacement therapy, we're replacing the losses. Okay, good job. Okay, Norma, number 12.
Priming the tubing to flush the air from the administration set with the solutions before using.
Right. Anybody been at the infusion center for your community site yet? Did you get to prime tubing? Yes, that's a great thing they do over there. So if you go there, just tell them you want to prime all the tubing, okay? It's a great day to practice that using your aseptic technique. Great place to go for this semester. Okay, good. So Trisha, number 13.
Spiking the vacuum, hoping it's fine in the back.
Yeah, so we're taking our spike, which I showed you earlier, right? This is what we call spiking the bag. Okay, so you hear that term. If the nurse goes, you want to spike the bag? You want to prime the tubing? Now you know what she's talking about. Okay. Okay, good. Okay, let's see who's next. Julie, number 14.
Macro drop, IV tubing to the drop after 10, 15, or 20 drops per minute.
Right. Okay, so that drop factor is extremely important for calculations. You got to know your drop factor to calculate your rate. It's located on the packaging. Okay, so Jenny, number 15. So a micro drip tubing or micro drop tubing, I don't have one in here, but there's a little needle that comes down in this chamber, and it's going to drop, it's for pediatric patients, it's going to drop 60 drops per minute. So when you hear the terminology mini drip tubing, it's synonymous with 60 drops per ml. Okay, so write that down. Mini drip tubing or mini drop tubing, 60 drops per ml. It's for pediatric patients. Okay? Okay, let's see. Han, number 16. Where's Han?
I have a different.
Do you have drop factor?
Yeah.
So what's the drop factor?
Gravity drip infusion only the number of drops used to deliver 1 ml of fluid.
Right, that's the number of drops that make 1 ml of fluid. So that's important for you to understand, wrap your mind around that. Okay, good. Okay, then number 17.
PCA clown is patient control anesthesia. The patient
Okay, number 19.
Four essentials of IV infusion are volume, time, salt factor, and formula.
Very good. Okay, and Ted, number 20. Ted.
Piggyback. An IV piggyback is a way to administer medication to the patient. IV is a tube that inserts into the patient's vein. It can be an antibiotic or a medication that would be medication IV piggyback makes a small amount of liquid.
Good job. Oh, excellent, Ted. Way to wind it up. All right, so piggyback is intermittent. Just remember, those are the same thing. Intermittent infusion is a piggyback. Trying to get you familiar with the terminology so that now when you're on the floor, you'll be like, oh, can I get your piggyback? Here's Mary. Like that. All right, good job. Okay, so we're going to do problems now. And this is what I'm going to do. I'm going to have one person come up from each row. And I'm going to, everybody in your seats, you'll be doing problems in your seats. So get out scratch paper. And so I'm going to have the first person in this, at every row right now, come up to the board and grab a Sharpie. Try to make room for each other. And then everybody in your seats, I also want you doing these problems, okay? And then if they need a lifeline from their row, I'm going to have you go up and help them. Let's go with that, all right? Okay, let's get up here, guys. It's going to be a competition. The rows against each other. Okay, spread out. Everybody needs space. Let's see if row 1, 2, 3, 4, 5, 6, 7. Okay. Okay, here we go. I don't want to do a drop back first. I know. Okay, you guys split out a little bit. Okay, you should be smack dab in the middle. Yeah. There's 7 people up here. But there's enough room for Okay, ready? Okay, the order reads, infuse 250 mLs of normal saline over 2 hours. Once you set the pump back. mLs of normal saline over 2 hours. What do you set the pump at?
Oh, man.
I'm going to go through your whole room and I'll come back. Good job.
I'm not allowed to remember.
Okay, I need somebody from his row to come up and help him. He needs a lifeline. But stay up there.
Simplify.
Okay, good. Good.
Get in my head.
The secret with getting these right is always do the formula and always do it the same way. And then you'll never be wrong. Okay? Okay, next person in that row, come on up. Person number 2 in every row, please move on. Oh my gosh, the last row, they're going to do. I hardly have anybody in the room. Okay, you can go ahead and erase those. Okay, the order reads 350 mLs of normal saline over 3 hours. What do you set the pump at? And everybody should be doing this feverishly at your desk.
What is it? How's it again?
350 ml of normal saline over 3 hours. What do you set the pump at? Let me see your mouth. 117? Oh, yeah. So you run that? Yeah. Okay. Yeah. Four below. Keep going. Keep rounding. No, you're fine. Just keep rounding. Yes. mL per hour. Yes. Awesome. Good. All right, third person. No decimal. Okay, third person in the row. So that means Ann, you have to come back up. You only have 2 people in your row.
Can we do it? It's like,
I need a representative from every row. This is a competition. Yeah. Okay, are you ready?
I'm sorry, guys.
500 mLs of D5W over 24 hours. This would be like a pediatric patient. Yeah, over 24 hours.
Hey, there's no phone in the front.
Doesn't really want a real lifeline.
It's probably more than this, right?
That one other one on the far right cheated.
All right, good. Okay, next person in every row, Luana. And come on back up. You're not good. You're not good. Okay, everybody, share the erasers. Okay, ready? Okay, the order reads 1,000 mL of D5 half normal saline over 5 hours. Where do you set the pump at?
Over how long?
5 hours.
Yeah.
That's a 5. Right? Wait. 5? Oh. 4?
Mexico.
There you go. Perfect. Yeah. All right, good. Is everybody getting the answer that's sitting in their seat?
Yes.
Okay, another representative from every row, please.
Alright. You bring your calculator from math class?
Yeah, that's not like you can't bring your laptop up there.
Okay, we're going to do our first drop factor question. All right, here we go. Ready? The order reads 1,000 mL to infuse over 10 hours. The drop factor is 60 drops per ml. How many drops per minute?
Per minute?
Yep. 60 drops, mini drip tubing. 60 drops per ml.
Did I write it wrong?
No. You need a lifeline?
Yeah, I need a lifeline.
Okay, that's fine.
I don't know how to do
Lifelines are acceptable at this stage.
over 1 ml.
I need 60 drops per ml. If you don't do it, conventional analysis, put it all out, I'm not sure.
It looks like, okay, so the other one is like the most error was the start of it. The drops over ml. Drops over ml is a one-dimensional.
So yeah, I would set up the whole problem. Start with the 60 drops over 1 I would do the multi-dimensional analysis. Yeah, this is correct. Okay, so let's. Okay, we need a lifeline for Ted. Ted needs a lifeline. Ted needs a lifeline. Somebody from row 1.
Oh man, you're not even with me.
You guys, the key to success on these problems is setting them up the same way every time. Start with your drop factor. That should start out your problem right there. Then go to your volume and your time, and then at the end you should have your 1 hour over 60 minutes. If you get this into your head to do it like this every time, you're going to get the right answer. I know it's a little tricky, but you guys did great. Okay, let's get another person. So Monica, we're back to you. Let's get another person from each row. You haven't been up yet. So that would be... Okay, yeah, raise everything really good.
Huh? What? It's a fucking
Okay, let me just have you scoot down a little bit to the right.
Hey,
Scoot down a little
that
more.
brotherly love. All 3 guys are all.
Okay. Is everybody ready? Yes.
Just watching my
Right out of my game. Okay, here we go. Position order 250 mLs of normal saline over 1 hour. The drop factor is 10 drops per ml. How many drops per minute? So 250 ml of normal saline over 1 hour. Drop factor is 10 drops per ml.
2,500 drops.
Thank you, Mila.
Yeah, good, yeah, Mila's on board. Do you have a calculator? No, what's your calculator? You need a lifeline. Joaquin needs a lifeline. Is the first one? No, you need a calculator. Oh. Okay. If your row's not represented, come on up. If your row is not represented, Joaquin's going to stay up for the next problem. So, I want somebody from all the other rows. Come on up.
I'll erase it for you.
My job.
Future job. All right. The key is setting up the problem. Can you scoot this way a little bit? And then just scoot over. Okay, ready? Okay, here's the problem. Everybody listen. Physician orders 350 mLs of normal saline over 3 hours. The drop factor is 15 drops per ml. How many drops per minute? 350? Drop. GTT is an abbreviation. Like the Latin, I think. Yeah. No. Here's a. Keep going, good. Rework it.
It looks right. That's what I thought.
Per hour? I got the bakery?
When time gets over 16 minutes over an hour. About 1 hour. I don't know what you did wrong last time.
Last meal, they was talking about.
Yeah.
Right.
Okay, well, try to do my calculator. Oh, 350 over 3 hours.
That's where I'm stuck up.
There you go. That'll fix it. Okay, if your row is not represented, come on back up. There you go.
1 hour.
There you go. There you go. Yeah. Yeah, you got it. Good job. Good thing. Okay.
Yes.
Yes.
I put it
No,
wrong.
it's 29. Just round down.
Who wants to do?
All right, here we go. You're stand up. You're doing another one. There you go. Stand up till you get it. Okay, ready?
Come on, buddy.
Okay, the doctor orders 200 ml to be infused over 60 minutes. tubing has a drip factor of 20 drops per ml. 20, yeah, 20. Okay. I keep getting the dead one. Okay. Frustrating. Good, Joaquin, did you get it?
Get it?
That's awesome. Good. All right, you can sit down. Yes. Well, with this question, it was given to me. So they Okay, next group, come on up.
Thank you. Your turn.
Okay, we need representatives from every row. Okay. Okay, how long will it take? It's tricky in the wording. How long will it take 0.5 liters at 125 mLs per hour to infuse? How long will it take 0.5 liters at 125 mLs per hour to infuse? There's no drop factor, so then you know it's not a gravity trip. 0.5 liters at 125 mLs per hour. How'd you get it?
Divided 500.
Yeah, that's
right.
500 ml.
500
500?
For a new one.
Where's your answer?
Above his head. Behind his head. There it is. 4 hours.
Oh, okay. Way over there.
I did because it was 120 or.
I didn't get that.
Every milliliter. Half a liter every. Yeah, half a liter is about 1 liter. Yeah.
Your volume that's infusing is 500 ml. Okay, that was a little tricky.
I didn't get it either way.
Okay, do another one. Okay, stay up. All right, let's get other representatives from the row to come on up. Okay, come on up. Come on up. Don't be shy. Do we have somebody from all the rows? 1, 2, 3, 4, 5. Nope. We're missing 2 rows. Stand it.
My math nightmare all over
I'll get
again.
an answer over it right now. Okay, are you ready? erase the old stuff, please. All right, here we go. The doctor ordered 600 mLs of normal saline with 10 milliequivalents of KCl. One more time. The doctor ordered 600 mLs of normal saline with 10 milliequivalents of KCl every 8 hours. The drop factor is 20 drops per ml. Calculate the drops per minute. So just forget about the KCl. Just cross that out. The doctor ordered 600 mLs of normal saline every 8 hours. The drop factor is 20 drops per ml. So your volume is 600 times 8 hours, drop factor 20 drops per ml. Repeat it. 20. 20 drops per ml. Sorry. Yes. So 600 ml.
Wow, what is easy, right?
Over 8 hours. Not quite, but almost.
It was per hour?
It's drops per minute. You were almost there. Your decimal point was close to 12. Yeah. Okay, you got it. Okay, there you got it. All right. Okay, let's do another one. Okay, let's get everybody up from the road. Okay. All right. Listen carefully. Listen carefully. There is 25 mLs to infuse over 30 minutes. There is micro drip tubing being used. Calculate the drops per minute. Micro drip tubing. Yeah.
What's the answer?
50
drops per minute?
No, 60 on micro drip. Oh, what do you want? 25 mL is the volume, 30 minutes is the time frame. Micro drip tubing. We already have that up there. Now you just need minutes over an hour.
See, I had 50. Wait, I missed it. Can I phone a friend, please?
Lifeline.
I need a friend, row 2. I got 50 cents wrong. Yeah, I had that. She said that you had.
All right. So you have 60 drops per
I know I got 50.
25 mL over 30 minutes. Where's your 1 hour? You can multiply your 60 minutes over 1 hour. Now do it right here. Well, now you should. Okay, come on. Look at this right here.
Yeah, 50 was my answer.
Oh, I didn't realize that.
Yeah, I think I was over 30 and then it was 50.
Oh, yeah.
Yeah, because I had and then you said, yeah, and then you said I had to.
Oh, I'm sorry. Okay.
Yeah, I have 50.
I didn't know you had 50.
That's what I had to.
I'm sorry, girl. I didn't see it. Sorry. Okay, well, good job. Right for the Okay, one more group. Come on up. Yep. Yeah, you say that now.
I can get it on paper and then I'll turn that.
You just gotta stand far.
But,
Okay, ready? Okay, 1 gram of Ansep and 100 mLs of D5W. 100 mLs D5W with your Ansep is to infuse over 30 minutes. What should the pump be set up?
Say it again.
Yes. 1 gram of Ansep and 100 mLs of D5W is to infuse over 30 minutes. What should the pump be set up? Sorry, I'm laughing. These should be 100 mLs over 30 minutes. If you multiply the 60 minutes over an hour. No drop factor. Just multiply 60 minutes over an hour. Times 60
It was my
minutes.
turn to go. That's what I realized.
No. Other way around. Yeah. Am I completely wrong?
Wait, could you
Forget about the 1 gram. Ignore that. This is all you need.
Is it 3 ml?
Okay, so that's just extra information.
Yeah, but you might get it like that. 100 ml over 30 minutes. So just multiply by 60 minutes. Yeah. Multiply 60 minutes over 1 hour.
I got 200.
Those are some fun questions. You're not getting any drop factor.
Is it 200?
Anybody? Anybody? No one got it? Everyone's got blank faces?
Is it 200?
Yes, it is.
Yeah.
200 ml. Good job, girls. Okay, so this is a typical piggyback. 100 ml piggyback will infuse in 200
Is it by hour?
ml an hour. Okay, one more member from each row, please. Since we're still not as confident as I want you to be. Okay, which rows are missing? I'm not seeing enough students up there. Porfirio, there's nobody from your row. Please appoint somebody.
I'll coach you right.
Oh, give me down. I remember when it was. Okay, here we go. Who else is missing? This row? So just pick somebody from your row. All right, here we go. Order reads 1 liter over 7 hours. Drop factor is 20 drops per ml. How many drops per minute? Drop factor is 20 drops per ml.
1 liter
Yes.
Yeah, we got the
Good job, good job.
Right on. Success.
You just said that up for you.
Okay, hello. Hello. Hello.
Just kidding.
Oh, did you ask for many
Got
or
around.
You said for many, right?
Yes, please.
Drop her.
Yeah, go team.
Okay, thanks. Okay, good. All right, good job. Okay. So on Wednesday, we're going to be watching a video regarding local and systemic complications of IV therapy. I want you to study that over the weekend, and then after we watch the video, I'm going to give you a quiz on local. Isn't that so fun? I know. I'm a blast. I know that.
It's going to be for third semester.
The third semester, you have a quiz every day. Every Wednesday, every Thursday. Yeah, every day. So, but the reason I want you to do this, I want you to study the complications, because this is a huge aspect of IV therapy, is identifying the local complications before they turn into systemic complications. And it's just the whole other half of what we've learned today. We've learned the calculations, we've learned just the basics, but now I really want you to study the complications over the weekend. It's part of your exam. I need you just to really jump in there and learn it. Yes?
Just a quick announcement from
Yes.
Professor Rowena.
Okay.
You guys remember what we did last semester where we helped her out? This Thursday, September 27th, 7:30 to
That's not this
9
Thursday.
p.m. Next week.
The 20th? No, that's 2 weeks. 27th. Our exam's on the 20th, so that'll be the following Thursday.
If
Yes.
you guys want to go and volunteer, it'll count like a stack stuff you need.
It's an extracurricular event on your clinical evaluation tool. So we regard that very highly on your clinical eval tool when you do these extracurricular events. Yes.
Oh, so there's a section meeting next week on Thursday.
Oh, on the day of the exam? That's okay, though. Saxon meeting,
15 to 12:15 at the W.
11:15,
11:50.
50. Okay, listen carefully. Saxon meeting next Thursday at 11:50.
11:15 to 12:15 is about third world country nursing.
Okay, that sounds awesome.
I don't know, I just have to sign up for it.
Okay. Thank you for remembering. Yep, you need to go to at least one Saxon meeting a semester. That's considered professional development. Okay? Yeah. Yes. Our quiz is going to be on complications of IV therapy. And so you have 2 slides in your PowerPoint. One is all systemic and one's all the local complications. Okay. Then you're going to get to watch a video where you see nurses responding to all that. Which if you study, it'll reinforce what you study. Okay? Then we'll do the quiz after. For Wednesday, yeah. Yeah, for class Wednesday. All right, have a good weekend.
Somebody's
Monday. Yeah, somebody's phone is up here.
I think it's water clear. I'll take it.
What kind is it? Can I sell it? No, that's not right.
We gotta do that report this weekend.
Joaquin, is this you? Jaquan. Jaquan, is this yours? Jaquan. Was that you that wrote fucking wife? Did you name that? Don't be sexy.